Hi, my name is Andrew Farage. I'm a radiation oncologist at Houston Methodist, and we're going to discuss central nervous system tumors in adults today. So, as a radiation oncologist, I primarily deal with central nervous system neoplasms. So, most CNS tumors are thought to be sporadic in nature, meaning that there's not a genetic predisposition syndrome. However, about 5% of cases are linked to a genetic precursor, such as Li-Fraumeni syndrome, tuberous sclerosis complex, or neurofibromatosis. CNS tumors can be either primary or secondary in nature, meaning that they either began in the central nervous system and they're very unlikely to spread elsewhere in the body, or secondary, meaning that they spread from another part of the body to the brain, and that would be most metastases from other types of cancers. The most common cancers to spread to the brain are carcinomas. So things I typically encounter in practice are melanoma, breast cancer, lung cancer, and other more rare things. Common symptoms can be headache, nausea or vomiting, or total neurologic findings. For instance, in an occipital lobe tumor, you may see visual changes, or tumor in the supracellular area. We can see homonymous hemianopsias. Other things we can see is a temporal lobe metastasis or primary tumor may present with seizures, which is commonly encountered, and frontal lobe may result in personality changes. Typically, the patient, if they present with symptoms, will come in and a CT scan without contrast will be performed. That's primarily to look for a stroke or a bleed in the brain. That will be followed by an MRI, and when we see a tumor on MRI, there are several characteristics that can help us determine what type of tumor this may be. So, for instance, a high-grade glioma, like a glioblastoma multiforme, those high-grade tumors will show T1 hyperintensity, so they'll take up contrast on the post-contrast images, and will also be associated with a lot of edema on the T2 weighted sequences. We typically use a T2 flare to determine how much edema is in the brain, because it subtracts the CSF signal in the ventricles. For many intracranial neoplasms, surgery is the primary treatment of choice. So, for instance, if it's a pituitary adenoma, macroadenoma that's coming out of the sella and approaching the optic nerves, the surgeon would go in and do something called separation surgery to move the tumor away from the optic nerve, and then that could be treated potentially with radiation therapy after the surgery. For other tumors like high-grade gliomas, typically the tumor is resected and treated with adjuvant radiation therapy, which may consist of 5 to 6 weeks of adjuvant treatment. For smaller tumors or tumors near critical structures like the optic nerve or brainstem, sometimes radiation therapy is used as the primary treatment modality. And for those patients, we use masks such as this one to keep the patient immobilized so that we can target even 1-2 millimeter structures in the brain with a very high dose, precise radiation treatment.